Bismillah ar-Rahman ar-Rahim. Welcome in this meeting of Egyptian Society of Nephrology and Transplantation, CME chapter meetings. And we are today having Professor Heba Hamdy, Head of Nephrology Department in Bani Suef University, and Professor of Medicine and Nephrology as the speaker today. Our topic today is about minimal change disease in adults. What are the specific criteria for this disease in adults, and what are the differences between adults and children for this disease, which is famous in children? I am to welcome Professor Hisham Said, Emeritus Professor of Nephrology and Transplantation in Ain Shams University and the President-elect of ESNT, to share us in this session and will share us in the discussion following the lecture. So please, Professor Heba, start your lecture and we'll come to you after the lecture for the discussion. Start.
Bismillah ar-Rahman ar-Rahim. Thanks, Professor Yasser. Thanks, Professor Hisham, for being patient for the technical error that happened to me today. I'm very sorry for the delay, but it's something out of my hands. هنبتدي بسم الله الرحمن الرحيم. Minimally changed disease in adults. Introducing the disease, minimally changed disease is a major cause of nephrotic syndrome in children. It's about 90%, and in a very minority in adults, about 10%. Minimally changed and focal segmental glomerulosclerosis are two entities that belong to the same entity, which is called the podocytopathy. Epidemiology, in addition to age, ethnicity, it is an important predictor. It's more common in the Asian population and white population, while the percentage of nephrotic syndrome patient with focal segmental glomerulosclerosis is usually linked to the APOL gene, which is more common in the African American population. Pathogenesis, the underlying cause of minimally change, is unclear. Accumulating evidence suggests that T-cell dysfunction results in the production of glomerular permeability factor. This circulating factor directly affects the glomerular capillary wall, resulting in marked proteinuria, food process effacement in the subset of patients with minimally changed disease. Autoantibodies directing the slit diaphragm component called the nephrin may contribute to the pathogenesis. T-cell dysfunction, the proof for the T-cell dysfunction is the remission is induced by measles infection, is that in children with glucocorticoid sensitive nephrotic syndrome, relapses were associated with decrease in the T regulatory cells. The lesion of minimally change occur more frequently in patients with Hodgkin lymphoma, as what Dr. Hisham was telling very recent. Glucocorticoid and cyclophosphamide, which modify cell-mediated response, have proven benefit in the treatment of minimally changed disease. Atopic individuals are at higher risk for the development of minimally changed disease. The pathogenesis, glomerular permeability factor, is a variety of observations support the possibility that a circulating factor of immune origin alerts glomerular permeability in minimally changed disease, thereby resulting in proteinuria. The identify of the glomerular permeability factor has been determined in humans. However, T helper lymphocytes are implicated, involving interleukin-13, which results, this is proven in rats by one experiment that shows that interleukin-13, when given to that rat, albuminuria starts, hypoalbuminemia, and on kidney biopsy, up to 80% of podocytes food process fusion by electron microscopy, and there is nothing shown by light microscopy. This is similar to those of minimally changed disease. Another candidate protein is the circulating hemopexin. Usually inactive hemopexin may become activated as a serine protease, leading to the nephrin-dependent cytoskeletal rearrangement in the podocytes and the change the permeability of the glomerular filtration barrier. The role of B cells was, for many years, thought that B cells has no role in minimally changed disease. But recently, with the era of rituximab, we found that rituximab is a good treating option for this patient, and they found that CD20 B cells population suggests that glomerular permeability factor could be produced by B cells or T cells through pathway regulated by or stimulated by B cells. This result in minimally changed disease, and this is supported by that rituximab patient positive sensitive to rituximab patient are usually glucocorticoid sensitive, but resistant to frequent relapser or steroid dependent. The pathogenesis: antinephrin antibodies target the nephrin, which is a protein in the slit diaphragm, cause massive proteinuria. And it have been shown to cause massive proteinuria when administered in animal models. And in many slides, many studies showed that antinephrin antibodies were identified in about 20% or 29% who had active disease at the time of sampling. Antibody titers were reduced or absent during clinical response of the treatment. Immunofluorescence microscopy revealed punctuate IgG deposits colonized with nephrin in the kidney biopsy of 9 patients. All of them were serologically positive for antinephrin antibodies. No punctuate deposits were seen after the serologic negative patient. One female patient with a childhood onset glucocorticoid dependent minimally changed disease progressed to focal segmental glomerulosclerosis and end-stage kidney disease following kidney transplantation. She rapidly developed recurrent nephrotic syndrome, which is associated with high risk of pre-transplant circulating antinephrin antibodies. With plasmapheresis, she experienced remission accompanied by the disappearance of antinephrin antibodies. This is a slide that shows what I was saying. The T helper cells downregulation lead to secretion of interleukin-4 and activation of B cells, which cause antinephrin antibodies, and the interleukin-13, which cause downregulation in the podocin and nephrin, which causes podocytopathy. The role of glomerular basement membrane: the endothelium of the glomerular basement membrane are strongly anionic, which is electronegative charged, being provided with sialic acid and heparin sulfate. Under normal circumstances, the negative charge for glomerular basement membrane repulses circulating albumin molecule, since albumin is negatively charged at neutral pH. This picture shows the negatively charged protein in the glomerular basement membrane down in the slide. The primary minimally changed disease is not clearly associated with an underlying disease or event, and this is considered to be primary. This usually happens in children, but the underlying cause of primary minimally changed is unclear. It's thought to be production of circulating glomerular permeability factor that directly affect the glomerular capillary wall, resulting in marked proteinuria and food process effacement. Secondary causes includes some drugs like non-steroidal anti-inflammatory, antimicrobial drugs like penicillins and cephalosporins, lithium dipenicillamines, pamidronate, sulfasalazine, gamma interferon, mercury, and immune checkpoint inhibitors. The other etiology for the disease are malignancy associated with malignancy, particularly Hodgkin lymphoma, and some underlying hematological malignancies. Usually, the degree of proteinuria parallels to that of the malignancy. When proteinuria disappearing when the remission of the malignancy is obtained following chemotherapy or radiotherapy. In some patients, minimally changed disease precedes the discovery of the lymphoma by itself by several months or even years. In 21 patients who had both minimally changed disease and Hodgkin lymphoma, about 38% of the patients were diagnosed of minimally changed disease before the diagnosis of malignancy by 2 years. One was glucocorticoid dependent and 4 were glucocorticoid resistant, but all the patient entered into a remission after lymphoma was treated. Other solid malignancies like the thymoma, mesothelioma, and renal cell carcinoma are attributed to the minimally changed disease. Infections may be attributed like syphilis and tuberculosis and mycoplasma. Allergy, the history of allergy has been described. 30% of cases with minimally changed multiple allergens have been associated. Even the bee sting, even the cat fur can cause the disease. Association with other glomerular disease, minimally change can be associated with mesangial IgA deposition and mild mesangial proliferation, suggesting the concurrent IgA nephropathy and minimally changed. The mechanism underlying this is not understood, and many reflect concurrent disease, especially in Asian individuals. Although the relationship is unclear, there are some reports in association with other glomerular disease like lupus podocytopathy and type 1 diabetes, HIV nephropathy. Some cases of SARS-CoV-2 vaccination was followed by minimally changed limited type of minimally changed disease at that era. In most patients, minimally changed disease is characterized by sudden onset over days or weeks to signs and symptoms of nephrotic syndrome, often following an upper respiratory tract systemic infection. Nephrotic syndrome, as we all know, is albuminuria, almost greater than 3.5 to 4 gram per day, occasionally more than 15 to 20 gram per day, weight gain, edema, laboratory testing, hypoalbuminemia, and some cases hyperlipidemia. Onset of the nephrotic syndrome is reasonably specific but not very sensitive. Usually it's a short course, but the onset should not be used to avoid the performing of a kidney biopsy. Other kidney manifestations that are seen, clinical finding at presentation illustrated in a retrospective analysis. The following findings were noted: age and laboratory results representing mean value. Microscopic hematuria can be seen in 20 to 25% of patients in children, but is not associated with a difference in the clinical course of the disease. The serum creatinine concentration may be modestly elevated at the presentation in both adults and children. Acute kidney injury is an infrequent complication and has been primarily described in adults. The pathological findings on kidney biopsy, the glomeruli appears normal by light microscopy, no component of immune globulin deposition in immunofluorescence microscopy. Glomerular size is usually normal by standard methods and light microscopy. The characteristic histological lesion is the effacement of the podocytes, which is called fusion of the podocytes in the epithelial foot processes in the electron microscopy. More specifically, there is retraction, widening, and shortening of the foot processes, and spaces between them are flattened. Podocyte foot processes are reduced in number, which may play a role in the excess of albumin load into the urinary space. The degree of effacement does not correlate well with the degree of proteinuria. Foot processes regain the normal appearance. This is a normal glomerulus foot processes, and this is the electron microscopy in minimally change. As we all see, the foot processes are fused together with no foot processes seen anymore. It's completely effaced. When to suspect minimally changed disease, the diagnosis of minimally changed disease suspected in adult patient presenting with symptoms and signs of nephrotic syndrome, especially if acute over days or weeks. All patients presented with nephrotic syndrome should undergo evaluation for glomerular disease, which is generally involving laboratory tested, and a kidney biopsy must be done, especially in adults. Usually children doesn't need many times biopsy except in resistant cases or frequent relapsers. Establishing the diagnosis, a kidney biopsy is required to establish the diagnosis of minimally changed disease in adults and to exclude other causes of nephrotic syndrome. There are no specific laboratory findings can be distinguished from minimally changed from other causes of nephrotic syndrome. In children, presumptive diagnosis is usually made upon clinical findings, and usually no need for a biopsy in children, except if the glucocorticoid resistant nephrotic syndrome. Testing for circulating antireferrin antibodies may be potentially diagnosed utility in patients who cannot do or do not wish to undergo a kidney biopsy. However, serological testing for antinephrin antibodies are not widely available. Not all the hospitals and not all the countries have antinephrin antibodies, but it may be useful in the future. Adult patients who are found to have minimally changed disease on kidney biopsy should be evaluated for potential underlying secondary causes, particularly malignancy, like Hodgkin lymphoma and thymoma, and drug exposure like non-steroidal anti-inflammatory drugs and pamidronate. Differential diagnosis, although diffuse food processes effacement is seen in other causes like primary FSGS, membranous nephropathy, and diabetic kidney disease and amyloidosis. These disorders have characteristic findings otherwise in immunofluorescence and on light microscopy. In some children, blood tests abnormalities that are not seen in minimally changed disease. Differential diagnosis distinguishing minimally changed disease from primary FSGS. This continues to be a debate as whether minimally changed and focal segmental glomerulosclerosis fall within the same spectrum. Many postulations, as they said that it's the same disease, but usually the focal segmental glomerulosclerosis start in the juxtaglomerular glomeruli, and the sampling usually comes from the outer cortical glomeruli. So this may be a missed sampling. With primary FSGS, biopsy diagnosis require the finding of segmental glomerulosclerosis at least in one glomerulus, in addition to diffuse food process effacement. However, sclerotic lesions are focal and affect the glomerulus, which be missed, leading to incorrect diagnosis of minimally changed disease. An example of sclerotic changes in biopsy only in the outer cortex, or biopsies that contain fewer than 8 glomeruli, with primary minimally changed disease is characterized by a full nephrotic syndrome, complete food process effacement, and electron microscopy. The complete response to immune suppressant and acute kidney injury, these are more to the side of FSGS. Importantly, in primary FSGS, response to immune suppression is seen only in approximately half of the patient, typically partial remission, and progress to chronic kidney disease in patient with persistent and high-grade proteinuria. Minimally changed variants, idiopathic mesangial proliferative glomerulonephritis. Proliferative glomerulonephritis is characterized by mesangial proliferation and in absence of IgG and IgA. Sometimes there is some IgM deposits present. Patients have isolated hematuria or nephrotic range proteinuria, whereas the kidney prognosis is favorable for patients with isolated hematuria and is not good for those with nephrotic syndrome, as 10 to 30% will develop progressive kidney function impairment. IgM nephropathy, which is found in patients with minimally changed disease, FSGS, and mesangial proliferation. Some experts, however, believe that IgM nephropathy is a distinct entity characterized by mesangial proliferation and prominent mesangial deposits of IgM and complement. Others require the presence of electron-dense deposits, and these are considered as a dense deposit disease. C1q nephropathy is characterized by mesangial proliferation, mesangial deposition of C1q in immunofluorescence microscopy. In patients with no clinical and laboratory evidence of systemic lupus erythematosus, C1q nephropathy may be associated with minimally changed FSGS and proliferative glomerulonephritis. The treatment is the same as for minimally changed disease or FSGS with no C1q deposits. The goals of therapy to achieve remission. Definition of response: complete remission is considered complete remission, reduction of proteinuria less than 0.3 gram per day of urine dipstick, or urinary protein creatinine ratio less than 300 milligram per gram with stable kidney creatinine and serum albumin above 3.5. Partial remission is reduction of proteinuria more than 50% from the start level with absolute values between 0.3 and 3.5 gram per day, with urinary protein creatinine ratio between 300 and 3,500. Partial remission lasting more than 2 weeks is an unusual event in minimally changed disease, occurring in 2 to 51% in one study. Furthermore, it is possible that prolonged partial remission may have an underlying focal segmental glomerulosclerosis, which is missed during sampling of the glomeruli. Definition of response: relapse. Relapse is the return of proteinuria above 3.5 gram per day after complete remission. Frequent relapsing disease is patient considered frequent relapser, 2 or more relapses in 6 months or 4 or more relapses in 12 months. Glucocorticoid dependent is our glucocorticoid refer to relapse occurring during or within 2 weeks of completing glucocorticoid therapy. Definition of response: also glucocorticoid dependent disease. Glucocorticoid refers to relapse occurring during or within 2 weeks of glucocorticoid therapy. Glucocorticoid resistance are the glucocorticoid resistant to proteinuria and or response less than 50% of the reduction from the baseline. This is the algorithm for the treatment of minimally changed disease. Initial therapy for primary minimally changed disease. For most adults with primary minimally changed disease, we suggest initial therapy with glucocorticoid monotherapy. For patients who cannot tolerate glucocorticoids or have contraindication to glucocorticoids, we have to go for glucocorticoid sparing regimen as an alternative option and include calcineurin inhibitor, tacrolimus, or MMF. Plus reduced doses of glucocorticoids. Glucocorticoid monotherapy lead to complete remission in 80 to 95% of adults with minimally changed disease. The time course to complete remission is prolonged with 50% response by 4 weeks and 10 to 25% requiring more than 3 to 4 months of therapy. Most glucocorticoid responsive patients will respond by 16 weeks, but some may respond at 21 weeks. يعني لازم نستنى for 21 weeks to say that this patient is not responsive to steroids. In some adults, remission may be observed during the period of tapering, when fixed duration regimen of glucocorticoids is used for induction of remission. By contrast, most children respond in 4 weeks. Initial therapy for primary minimally changed disease. However, relapsing disease, glucocorticoid resistant, and drug-related adverse effects are common issue among adults receiving prolonged high-dose glucocorticoids. For this reason, glucocorticoid sparing immune suppressive regimen like calcineurin inhibitor MMF have been tried to reduce the toxicity of long-term glucocorticoid therapy. Data suggests that such glucocorticoid sparing regimen appear to have similar efficacy and safety compared to glucocorticoid monotherapy and may reduce the rate for relapse. A randomized controlled trial that treatment with intravenous methylprednisolone for 10 days followed by oral tacrolimus starting in the dose of 0.05 milligram per kg per day with a target trough level 4 to 8 nanogram per milliliter was comparable to prednisone 1 milligram per kg per day at inducing complete remission over 36 weeks. Rate of relapse were also similar between the two groups. Similar findings were reported in another randomized trial that compare tacrolimus monotherapy with IV methylprednisolone with prednisone. This is the study. They show that one arm was tacrolimus and one arm was prednisone. The remission is about 84%, 92%, and 92% comparable remission rate, and relapse rate is comparable in the two groups. Initial therapy for primary minimally changed disease. A trial randomly assigned 144 adults with minimally changed disease received tacrolimus 0.05 milligram twice daily plus low dose prednisone 0.5 milligram per kg per day, or prednisolone alone 1 milligram per kg per daily for up to 8 weeks or until achieving complete remission. Rates of complete remission at 8 weeks were comparable between the groups, 79 versus 77%. Fewer patients in the tacrolimus group experienced a relapse over 24 weeks, and the rates of adverse effect were similar in two groups. In the multi-center study, one label randomized trial of 116 adults with minimally changed disease compared enteric-coated mycophenolate sodium 700 milligram twice daily plus reduced dose of prednisone 0.5 milligram per kg per day, maximum the dose of 40 milligram per day, with conventional high dose prednisone alone 1 milligram per kg per day. Maximum 80 milligram per day, and there is no significant difference between the treatment arms and the rate of complete remission after 4, 8, and 24 weeks of treatment. Among the patients who achieved complete remission after 4 weeks of treatment, rate of relapses were comparable between the two groups, and the frequent serious side effects are also similar between the two treating arms. Glucocorticoid monotherapy, we usually start with prednisone at the daily dose of 1 milligram per kilogram per day, maximum 80 milligram per day. Some protocols prefer 2 milligram per kg per day every other day to minimize the toxicity of long-term daily prednisone. Therapy is usually given as a single dose, awakening at 7 to 9 a.m. in an attempt to minimize adrenal suppression. We continue the initial therapy for 4 weeks. One observation study compared a shorter duration 2-month glucocorticoid regimen with a conventional glucocorticoid regimen in adults, found similar rates of overall frequent relapse between the two groups. The cumulative effect of glucocorticoid dose was markedly lower in the shorter arm duration. Tapering, slow tapering is performed to sustain the remission and to avoid adrenal suppression. Short tapering regimen in which glucocorticoids are tapered rapidly after the remission is induced are associated with increased risk of relapsing, suggesting a rebound effect for patients who respond with complete remission. We start tapering prednisone 1 to 2 weeks after complete remission is attained. Approach to tapering prednisone vary among clinicians. One approach is to reduce the daily prednisone dose by 5 to 10 milligram per week for a total period of glucocorticoid exposure 16 to 20 weeks. In a patient who have not attained complete remission, the usual maximum duration of daily or alternate day prednisone at initial is 16 weeks, and the patient who did not respond at that time considered a glucocorticoid resistant. In such patient, prednisone therapy is gradually tapered to lower the dose, and cyclosporin is started. Again, to the algorithm for the treatment of our patient, glucocorticoid sparing regimen, alternative treatment option who cannot tolerate to glucocorticoids, calcineurin inhibitor, cyclosporin or tacrolimus, cyclosporin 3 to 5 milligram per kg per day in 2 divided doses to maintain whole blood trough level between 150 to 200 nanogram per milliliter. If tacrolimus is used 0.05 to 0.1 milligram per kg per day in 2 divided doses to maintain whole blood trough level between 4 and 7 nanogram per milliliter. Once the patient had achieved complete remission, we continue these doses for additional 12 weeks, then gradually taper the dose over 8 weeks to discontinuation. The total duration of treatment is approximately 6 months. In patients who have contraindication or who do not wish to receive glucocorticoid, calcineurin inhibitor can be administered as monotherapy in the absence of contraindications. Some clinicians administer calcineurin with reduced dose of glucocorticoids 0.3 milligram per kg per day, maximum dose of 30 milligram per day. Although the addition of glucocorticoid to calcineurin inhibitor is not necessary, once the patient have achieved a complete remission, the prednisone is tapered over 4 to 6 weeks to discontinuation. MMF is used first week 0.5 milligram twice daily, then increase the dose to 1 gram twice daily. Enteric coated mycophenolate sodium is used in the dose 360 milligram daily, twice daily in the first week, then increase the dose to 720 milligram daily in the next weeks. We usually continue these doses for the total of 6 months and then discontinue the doses administered with reduced dose glucocorticoids. We give prednisone 0.5 milligram per kg per day, maximum dose of 40 milligram per day. Once the patient has achieved complete remission, we taper the prednisone over 4 to 6 6 weeks to discontinuation. Some experts choose to taper the prednisone more gradually over 4 to 5 months. Supportive measures, as all nephrotic syndrome patients, these patients need to have supportive measures like salt restriction, like blood pressure control, ACE inhibitor or angiotensin receptor blockers, statin therapy for the risk of hyperlipidemia, and anticoagulation for the risk of DVT and hypercoagulable state that is present in this patient. Usually, it's not needed in minimally changed disease, except the patient who have prolonged courses for glucocorticoid therapy, which are more prone to this and adverse events. This approach is consistent with the KDIGO guidelines 2021. Monitoring the response of therapy. All patients who receive treatment for primary minimally changed disease should be closely monitored for clinical response to therapy. We perform clinical assessment and monitor spot urine to creatinine ratio, serum albumin, serum creatinine monthly basis. Remissions are typically abrupt when the patient being free of proteinuria and decrease in the edema. In majority of cases, response of therapy is one of all or none rule. Partial responses are not characteristic of minimally change, and usually partial response raises the issue for the misdiagnosis of FSGS and missampling error. Relapsing disease relapse defined as return of proteinuria, which have been previously undergone to complete remission. This is usually followed by decrease in the serum albumin concentration from its previous baseline. Approximately 50 to 75% of glucocorticoid responsive adult will have a relapse, and frequent relapses occur in 10 to 25%, glucocorticoid dependent in 25 to 30%. Most relapses occur within 1 year of glucocorticoid therapy has been tapered or discontinued, although some patients recorded to have a relapse after 25 years of remission. Relapses may be triggered by allergies, infection, especially virals, and some patients develop relapses after SARS-CoV-2 vaccination in the COVID era. Patient who relapse require reinstitution of the initial therapy. Early detection is beneficial. Once the patient had achieved complete remission, we ask them to test their urine with a dipstick of protein in 1 or 2 weeks period. A positive test should be repeated the next day. If still positive, we have to contact the clinician. Most cases of relapse have an abrupt onset, and the patient often self-diagnosed by a frothy urine or the edema which appears again. Infrequent relapse, these are patients who has infrequent relapse, receive glucocorticoid as initial therapy, usually administered a repeat course of glucocorticoid. An exception is in the patient who have previously developed significant adverse effect related to the initial therapy with glucocorticoid. In such patients, switching to a glucocorticoid sparing regimen is preferred. The optimum dose and the duration of glucocorticoid for the infrequent relapses uncertain, but usually they prefer to give shorter courses for this patient. The patient who relapse once per year or once in 2 years usually give a shorter course for the initial therapy of the same dose of the glucocorticoids. Subsequent relapse, if not frequent, it can be treated with prednisolone. Side effect has not developed. A longer course of prednisone is administered as in initial therapy. If patient received the glucocorticoid sparing regimen or mycophenolate mofetil plus reduced doses of glucocorticoid, we give the same treatment of the initial treatment. I will go faster. Minimally changed disease treatment, the same slide. Again, we go to the general approach of the patient with frequent relapsing, minimally changed disease. This frequent relapsing patient cannot usually tolerate glucocorticoids for a very long periods of time. So we think of cyclophosphamide and rituximab. The choice among these regimens depend upon several factors, including clinicians and patient preferring drug availability and cost, efficacy and toxicity and tolerability. Frequently relapse in general population, frequently relapsing and glucocorticoid dependent minimally changed disease who are in a relapse should be treated with glucocorticoids and glucocorticoid sparing regimen until remission is attained before a second line therapy is initiated. Following initiation of second-line therapy, glucocorticoid or a glucocorticoid sparing regimen are gradually tapered to discontinuation over 1 month. If possible, if the patient continues to be dependent on glucocorticoids and after 3 to 6 months of treatment, then the second-line therapy should be discontinued and an alternative regimen should be considered. The hazards, cyclophosphamide is a good option for this patient, especially, but the issue of the infertility is a very important issue because these patients, young adults, usually we don't prefer cyclophosphamide. If cyclophosphamide is used for patient, we should not administer again. If it is first time to give cyclophosphamide, we administered oral cyclophosphamide in a dose of 2 milligram per kg per day, maximum daily dose of 200 milligram for 12 weeks. Data in adults and children indicate that 8 weeks course may be less effective. The dose of cyclophosphamide is reduced as needed to maintain white blood cell count above 3,500 cells per microliter and absolute neutrophil count above 1,500 cells per microliter. Given the side effect of cyclophosphamide, prolonged therapy above 12 weeks and the repeated courses should be avoided. Cyclophosphamide evidence of efficacy in adults come primarily from one randomized controlled trial and several observational studies showed that cyclophosphamide induced remission in 75% of such patients. In a study of 14 patient, treatment of cyclophosphamide resulted in complete remission, free remission in 4 of 5 frequent relapsing patients and 4 of 9 steroid-dependent patients. The remaining 5 glucocorticoid dependent patients were able to be weaned from glucocorticoids but has subsequent relapse. At final follow-up, 11 patients were in complete remission. Rituximab is anti-CD20 monoclonal antibodies. If rituximab is used for patients, we typically administer rituximab as 1 gram الو الو الو
ايوه يا هبه، احنا سامعين.
معايا. اوكي
ايوه.
اوكي I'm gonna got it. Okay, rituximab. Some experts choose to administer maintenance rituximab. Rituximab given in a dose of 1 gram initially, followed by 14 days later by another 1 gram dose. Other clinician may be used alternative regimen administered 375 milligram per meter square weekly for 4 successive weeks, or B cell count deriving approach, which is the second dose given if there is more than 5 circulating B cells are detected by flow cytometry 1 week after treatment. In patients who respond to rituximab, some experts choose to administer maintenance rituximab to prevent relapse. There are no data to guide the approach. Some contributor to this topic would give rituximab 1 gram every 6 months for 2 to 3 years and then discontinue maintenance therapy. ليه تعليق صغير جدا. rituximab usually, because it's much more expensive, is usually saved for the patients who are planning to become pregnant, especially females who cannot take cyclophosphamide and cannot go on for prolonged time glucocorticoid regimen, and calcineurin inhibitors are and MMF are not a good option for them because of planning to become pregnant. Rituximab observational studies suggest that rituximab may be an effective therapy in adults. In a systemic review and meta-analysis, 21 studies involved 382 patients with minimally changed disease or focal segmental glomerulosclerosis. Rituximab therapy induces complete remission in 92% of those patients, although 28% of a patient relapsing follow-up. Rituximab was well tolerated and associated with fewer side effects. Other anti-CD20 monoclonal antibodies, optinuzumab, have been evaluated in the treatment, but also no enough studies for this because of the expenses. Calcineurin inhibitor for these patients, frequent relapsant or glucocorticoid dependent. If cyclosporin is used in this patient, the initial dose is 3 to 5 milligram per kg per day in 2 divided doses to maintain the trough level between 150 and 200 nanogram per milliliter. If tacrolimus is used, 0.05 to 0.1 milligram per kilogram per day in 2 divided doses to maintain the trough level between 4 and 7 nanograms per milliliter. The optimal duration of therapy who respond is not known, but prolonged therapy is given to minimize the risk of relapse. We treat with the initial dose of a calcineurin inhibitor at least 12 to 18 months, then taper to the smallest dose that maintain a remission and avoid nephrotoxicity, preferably less than 3 milligram per kg per day of cyclosporin or less than 0.05 milligram per kilogram per day for tacrolimus. The dose is maintained for 18 to 12 months, then slowly taper to discontinuation over 4 to 6 months. Calcineurin inhibitor, also cyclophosphamide, is potentially nephrotoxic. It appears that prolonged therapy with lower doses of cyclosporin may maintain remission without nephrotoxicity. In one study, for example, patient who went into remission and showed no signs of cyclosporin nephrotoxicity on repeated biopsy at the mean of 20 months, as long as daily dose of cyclosporin was below 5.5 milligram per day. MMF is used for patients. For this patient, start with 0.5 milligram twice daily and then raise to 1 gram twice daily, or intake-coated mycophenolate sodium 360 twice daily in 1 week, then increase the dose to 220 for twice daily. at least 1 year, then the attempt to gradually taper the drug and discontinuation if possible. Data for the mycophenolate in patients with frequent relapse and glucocorticoid dependent minimally change are limited but suggested most beneficial. As an example of observational study, 18 adults with minimally changed frequent relapse and glucocorticoid dependent who received MMF plus a low dose prednisone 10 milligram per day. 16 patients, about 89%, achieved complete remission, 1 achieved partial remission, and 1 was resistant to MMF. Among the 11 who completed the first cycle of MMF, 764 patients maintained the remission at least 33 months. Approximately the glucocorticoid resistant minimally changed disease, approximately 5 to 10% of adults with minimally changed disease appear to be glucocorticoid resistant. However, some experts postulate that this is not a minimally changed disease. This is a misdiagnosis of sampling, and this disease, if sampled again, this might be an FSGS. Again, causes of glucocorticoid resistant, inadequate initial glucocorticoid therapy. The patient is not adherent to his dose. The patient is receiving another drug like antacids, aluminum-containing antacids, which may interfere with the absorption of the doses. Incorrect diagnosis, another common cause for apparent glucocorticoid resistance, that sampling error has occurred. Minimally changed variant, as we said before, IgM nephropathy or C1q nephropathy. The role of repeated kidney biopsy, the value of repeated kidney biopsy in patients with glucocorticoid resistant minimally changed disease is unclear. Histological examination will show either FSGS or minimally changed disease. However, if minimally changed disease is again seen, one cannot exclude underlying FSGS that was missing by sampling error. Furthermore, findings on repeated biopsy do not affect the therapy, since the treatment of choice is cyclosporin for both glucocorticoid resistant minimally changed disease and glucocorticoid resistant FSGS. The role of repeated biopsy, on the other hand, some experts consider the finding of FSGS of repeated biopsy. يعني في بعض الناس بيقولوا ما نعملش biopsy تاني، خلاص هو كده كده treatment واحد. في بعض الناس بيقولوا لا، لازم نعمل another biopsy because the biopsy is valuable in glucocorticoid resistant patient since it identified a patient. On the other hand, some experts consider the finding of FSGS in repeated biopsy valuable in glucocorticoid resistant patient, and it identify worse prognosis, and even though it doesn't modify the choice of management of the disease. Repeated kidney biopsy indicated in patients treated with calcineurin inhibitor in whom there is rise in the serum creatinine, thinking of might be a vascular complication from the cyclosporin, the disease, and the proteinuria is from cyclosporin toxicity, not from the initial disease. This is again the algorithm for our treatment of glucocorticoid resistant minimally changed disease. In general, we treat this patient with calcineurin inhibitor, cyclosporin, or tacrolimus with or without low doses of glucocorticoid, usually the same approach as those patients with glucocorticoid resistant FSGS. Cyclosporin has documented efficacy in glucocorticoid resistant minimally changed disease, although long-term effect results are less well defined. In a report from France that contribute to prospective uncontrolled trial, 21 adults with glucocorticoid resistant minimally changed disease were treated with cyclosporin with or without prednisone. 14 patients were in complete remission at 6 months, but incomplete or partial remission at 6 months, but may have recurrent proteinuria upon cyclosporin taper. Responses were more likely among those concurrently receiving prednisone. Thank you.
Thank you, Professor Heba, for this comprehensive lecture about minimal change disease in adults. And I think the main differences between minimal change in adults, you mentioned, and correct me if I am wrong, that secondary lesion, we should search for the secondary lesion. If we find the minimal change, thoroughly, not take it lightly, especially drugs such as non-steroidals, pamidronate. The acute onset of nephrotic syndrome occurs more acute than children. Frequency of AKI is more than in children, and the need to biopsy, there is more need to biopsy to differentiate between lesions.
The rule in adults is to biopsy.
Yes, the rule in adults is to biopsy. There is more partial response patient than the complete response patient, and the time of response is more delayed in adults. If the patient will respond to steroids, is more delayed in adults than in children.
Yes.
Do you agree with me for these differences?
Sure.
Okay.
The debate is that is minimally change and FSGS are the same disease, and the diagnosis or the glomeruli affected is more juxtamedullary glomeruli and not detected on sampling. This podocytopathy issue. Is there two diseases or one disease with different stages of diagnosis on our diagnosis? This is the debate.
This is okay. Professor Hisham, you have a comment?
Thank you very much يا هبة. It's very informative يعني فعلا slides very informative, texting too much طبعا في كل trial. Just I am wondering in one question, I never use MMF in minimal change. I don't have the experience of MMF, but I use always tacrolimus or cyclophosphamide or cyclosporin. So just wondering if you have a trial on MMF on cases of minimal change or not.
I don't the guidelines حضرتك هي اللي كانت قايله
ما انا عارف انها جايد لاينز وحطها سكند لاين اوف تريتمنت، بس انا عمري ما استخدمته. يعني دايما
ما هو معظم الناس هنا في مصر because of the cost of MMF and because most of these patients are young females and usually we are afraid of giving them MMF for the يعني أنا كان عندي عيانة بنوتة كانت minimally change وهي طفلة وجالها وفريكوينت ريلابسر كانت ماشية كنترولد كويس على MMF. كانت عندنا في بني سويف، بس المشكله بتاعت البنوته دي ان اهلها جم دكتوره هي خلاص عايزه تتجوز يعني.
لا طبعا ما لازم هيقف
فاضطرينا يعني ان احنا نتشينج على تاكرولومس علشان خاطر البنوته دي ان احنا تقدر تتجوز لانها MMF.
يعني التاكرولومس فيرست لاين عن الMMF يعني.
أيوة صح كده حضرتك. بس هو في يعني انا شفت عيانين فعلا بروفن ان هم كانوا كويسين كنترولد على الMMF بس اضطروا ان هم ياخدوا
يعني
تاكرولومس
انا يعني كل الحالات اللي شفتها مينيمال تشينج ريسبوندنج على الCNI مع لو دوز ستيرويد، عمري ما استخدمت او لقيت ان انا محتاج ان انا ازود MMF.
هو مع الافيلابيلتي اوف بروجراف دلوقتي او التاكروليماس يعني
بالظبط.
يعني في المينيمال تشينج ليجن واحنا سبوزنج المينيمال تشينج ليجن نورمال كدني فانكشن يوجوالي احنا يعني الكومن براكتس ان انت تيوز التاكروليماس. MMF يعني مش في المينيمال تشينج، يعني عاده بيبقى another ستيب في FSGS لو
في FSGS
مشكله في الكدني فانكشن اليفيتد سيرم كرياتين او فبيبقى هو اوف تشويس. لكن في المينيمال تشينج مع وجود البروجراف ونو بروبلم وذ بروجراف بتبقى او تاكروليماس اي ثينك البرايورتي فور تاكروليماس طبعا مع وجوده يعني.
طبعا يعني انا ما احتجتش ان انا استخدم MMF خالص لان هو كان ريسبوندنج كويس على ستيرويد تاكرولومس. الحاجه الثانيه اتفضل.
يعني اي ثينك ان هو حتى البيشنت لو didn't respond to tacrolimus هنبقى نبتدي نفكر بقى في مش في ام ام اف، هتبتدي تفكر بقى في اذا كانت تدي
ريتوكس
ريتوكسيماب على
ريتوكس
طول او حاجه ثانيه،
بالظبط
لكن مش
ريتوكس.
هتكون
بالظبط
ما هو
الخطوه.
العيانه بتاعتنا دي
ده
خدت
choices.
شويه ريتوكس، بس البنت كانت كبرت وسابت المدرسه، فاهلها ما قدروش يوفروا الدوزز بتاعت الريتوكسيماب اللي هي كل 6 شهور، فالبنت ريلابست، فاضطرينا ان احنا وقفت الام ام اف ووقفت الريتوكس، فاضطرينا ان احنا في الاخر خالص، دي عيانه كانت عندي يعني لحد دلوقتي لسه بنتابعها، في الاخر خالص اضطرينا ان احنا نعمل لها قرار بتكرالمس،
طيب احنا عندنا
الحاجه
questions على
اتفضل.
وهي كنترولد كويس على التكرالمس، يعني هي فعلا كنترولد كويس على التكرالمس، بس
يعني ده
البنت
اللي
دي،
لفت نظري الموضوع الام ام اف طبعا يعني.
بس هي يعني بتوع الاطفال كانوا ماشيين على ام ام اف، يعني هي لما جات لنا من الاطفال كانت ماشيه على ام ام اف، بس بتوع الاطفال اضطروا يوقفوا الام ام اف، لان اما تمت 15 سنه باباها كان عايز يجوزها، فقال لها لازم تبطلي الام ام اف عشان خاطر الجواز، وخدت ريتوكس وريسبوندد على
I
الريتوكس
think
ورجعت
I
تاني.
think just المسج يعني عشان بس لو معانا جينيورز، هو
اه
ستيرويد وسين او تاكرولوماس هو ده الجولدن ستاندرد في المينيمال تشينج.
بالظبط كده.
السكند لاين بالنسبه لي هيبقى ريتوكسيماب، مش هيبقى السيلسيب.
اه
عمري ما احتجت ان انا ادي سيلسيبت في مينيمال تشينج الا اذا كنت بقى في حاله لوباس بقى او بودوسايتوباسي بتاعت لوباس، حتى ما بقاش في بروليفريشن. الحاجه الثانيه مهمه قوي انت عرضتيها، الاي كي اي.
اه
موصوف الاي كي اي في المينيمال تشينج مش بس عشان الهايبوفوليميا والهايبو البومينيميا، عشان الاندوثيلين 1 ريليز، وده بيعمل اسكيميك تيوبلر انجري.
اه
وموصوف في حالات المينيمال تشينج، يعني مش sudden onset of heavy proteinuria، بيبقى رابid رايز للبروتينوريك افكت، يعني اندوثيلين بيزيد، وممكن يبقى presented by AKI but still the common cause is hypovolemia.
مم.
لكن ما ننساش ان تيوبلر انجري ممكن يحصل من الاندوثيلين. بس واشكرك
ممكن.
شكرا جزيلا على محاضره قيمه جدا يعني.
ربنا يكرم حضرتك، شكرا جزيلا.
شكرا يا هبه. احنا عندنا في questions على الشات. هبه ستوب شير بليز. ستوب شير.
ستوب شير اوكي. شات رياكشنز، انا بحاول استوب شير، ستوب الفيديو مش قادره.
ستوب شير. ستوب شير مش ستوب فيديو. ستوب شير. المربع اللي تحت ده، ايوه تحت هي احمر اهي، الاحمر ده احمر
الاحمر اوكي
دوس بس.
خلاص.
اوكي. احنا عندنا في حاله، يعني هي عن parotid enlargement adult case of yearly relapsing minimal change over 12 years. Parotid enlargement precipitated by infections, especially upper respiratory tract infection, with excellent response to steroid for 6 months. Started 60 milligrams daily, withdrawal over 5 months, then 10 milligram reduction each month, or alternative days regimen with high dose 120 every other day او short source. واضح ان بيحصل ريلابس وكل مره بيرسبكت بالقصه دي.
دي
or patient
frequent
refused
relapse.
other alternative refuses other alternatives. for relapse بيحصل بتاخد steroids بس. she is so happy with the steroids and refuses repeat renal biopsy. renal function tests always normal blood pressure, sialadenitis, sarcoidosis, Sjogren's, lupus excluded. السؤال: is there any relation between parotid enlargement and relapsing minimal change disease and duration of the alternatives 1 to 2 years frequency of relapse after withdrawal؟ مش فاهم السؤال الأخير ده، بس يعني الريليشن مع الباروتيد.
باروتايتس باي اتسلف انا ما عنديش حاجه، بس ممكن ده يكون فيرال باروتايتس، وفي فيري يعني ريليشن محترمه بين الفيرال انفكشنز والاندكشن بتاع الاتاك بتاع المينيمال تشينج، يعني very much recorded ان ممكن تكون دي فيرال باروتايتس، والفيرال باروتايتس هو السبب في بدايه الديزيز اجين، بس هل هتقعد طول عمرها عندها فيرال باروتايتس؟
كل مرة بيحصل فيرال باروتايتس.
ما هي دي الغريبه.
صعبة شوية.
هو الفكرة ان عينة زي دي المفروض دي بتتحط كفريكوينت ريلابسنج، فالفريكوينت ريلابسنج دي هنبتدي مع الجلوكوكورتيكويدز، المفروض اكوردنج للجايد لاينز ان احنا نبتدي ندي كالسينيورين انهيبيتور معاها ايذر سايكلوسبورين او تاكروليمس او MMF. بعض الستاديز بتقول انه MMF، بس هو فعلا زي ما دكتور هشام بيقول هو معظم vast majority of the studies بتقول سايكلوسبورين او تاكروليمس.
اوكي. يعني you don't have information about the relation of parotitis.
لا، الباروتايتس ممكن تكون فيرال باروتايتس،
لا مع
والفيروس هو اللي
يعني
اللي بينديوس المينيمال تشينج.
السبيسيفيك ريليشن مع الريكارنس للباروتيس. ما هو
لا
باروتايتس اوكي، هم اكسكلودد، عملوا اكسكلوجن لكل حاجه.
لا، مفيش ريفيو بيتكلم على الباروتايتس بيرسي.
حازم ابو شوشه اور كوليج في السي ام اي. Great talk and very enlightening. Thank you. I have two questions. Since proteinuria is considered a marker for renal progression, why do many minimally change disease patients experience frequent relapses without developing any renal impairment? ده سؤال. If the patient was clinically diagnosed as minimally changed disease and refused biopsy for years, but when finally did the biopsy, it showed FSGS, how can we tell if it was FSGS from the beginning or minimally change that evolved into FSGS? هي
هو
المينيمال
ده
تشينج I
الديبيت
think
اللي
ان
انا
هو
بتكلم عليه. هما الاثنين بودوسايتوبيسز، فهل هي كانت كده وقلبت ولا هي من الستارت FSGS ونوت دايجنوزد غير لما عمل البيوبسي؟ No one can tell.
هو
حتى
يعني كان في
الافيسمنت نفسه، يعني برايمري FSGS والافيسمنت العنيف اللي معاه مش هيديني. لكن انا لو لقيت حتى اي انترامبنت الاميونوجلوبولين ولا اي حاجه، يعني اي ثينك هيبقى صعب قوي، يعني في الاخص ان ما عنديش بايو ماركر واضح.
مفيش
ما عنديش
بايوماركر واضح
بايوماركر.
ومفيش لاين اوف ديماركيشن بتوين ذا تو ديزيزز، لدرجه ان في ريفيوز دلوقتي بيسموهم بودوسايتوباثي. يعني في ديزيزز، في دلوقتي ريفيوز بيقولوا ان هم وان انتيتي، بس احنا في
ما
الوقت
هي
اللي
هو
احنا
انتيتي، ما
شخصنا
هو وان سبيكترم، ما هو وان سبيكترم على طرفه
هو وان
المينيمال تشينج
سبيكترم
والطرف
بالظبط.
الثاني. وغالبا البيشنت اللي بيبقى FSGS هو كان FSGS فروم ذا ستارت.
بس احنا
يعني
ما عرفناش ندايجنوز فروم ذا ستارت.
هو غالبا كان FSGS فروم ذا ستارت، كان ايرلي بقى او ستارتنج تو ديفلوب، بس هو وان سبيكترم وعشان كده بيتحرك من هنا لهنا. لو فضل مينيمال تشينج اوكي ذس ويل بي مينيمال تشينج انت، انما لو نقل لمينيمال تشينج على الطرف الثاني من السبيكترم I think he was minimal change from the start.
فروم ذا ستارت.
دكتور محمد الدريمي عنده question، بيقول CNIs are preferred in steroid resistant، وده اللي احنا اتفقنا عليه كنا بنتكلم فيه. Retox is preferred in steroid dependent او steroid sparing زي ما كنا بنتكلم دكتوره هبه ودكتور هشام. طيب كده احنا we have no more comments ومفيش questions تاني. Thank you هبه. احنا يعني
انا اسفه جدا اني اخرتكم
ما فيش
وسهرتكم،
حاجه.
انا اسفه والله، بس هو انا خلاص انا خدت القرار
استمتعنا الحقيقه.
الحاسم ان انا هغير اللابتوب. ده لازم،
طب
ده
كويس،
لازم.
ده شيء جميل، بس احنا مالناش دعوه، هتجيبيه على حسابي، هتجيبيه على حسابي،
لا
هتجيبيه على
انا
حسابي،
هجيبه انا،
مالناش دعوه، احنا مش هندفع
لا
حاجه.
هجيبه على حسابي اكيد طبعا. لا عشان الشغل، عشان الشغل بتاعي.
ان شاء الله.
ان شاء
ان شاء
الله،
الله
ان شاء الله
باذن الله،
بعزمينا بقى ما تجيبي كده.
باذن الله،
جزيلا
باذن الله قريب
شكرا
باذن
دكتور هبه.
الله.
نشوفكم
شكرا
على خير
دكتور
ان شاء
ياسر،
الله.
اشوفكم على خير باذن الواحد
بروفيسور
الاحد باذن الله،
يلا تصبحوا على خير.
coordinator of this
وحضرتك باهل ان
session
شاء الله.
عبد الرحمن lecturer of nephrology in Cairo University. Thank you for being the coordinator of this session. يلا تسمحوا لنا نقفل الحلقه، نختم
اتفضل.
الحلقه وتصبحوا على خير.